This is Chapter 13, Personality Disorders. So we start by taking a look at what personality is. It's defined as a unique and long-term pattern of inner experience and outward behavior. And traits are referring to particular characteristics that lead us to react in a predictable manner. Criteria for a personality disorder in the DSM-5 is an individual that displays a long-term, rigid, and wide-ranging pattern of inner experience and behavior that leads to dysfunction in at least two of the following realms: cognition, emotion, social interactions, impulsivity. The individual's pattern is significantly different from ones usually found in his or her culture, and the individual experiences significant distress or impairment. So again, a personality disorder is an enduring, rigid pattern of inner experience and outward behavior that impairs a sense of self, emotional experience, goals, and capacity for empathy and/or intimacy. It typically becomes recognizable in adolescence or early adulthood, and the symptoms last for years. It's been estimated that 10 to 15% of all adults may have a personality disorder. And it's often comorbid, meaning that it exists in addition to another mental health disorder. Some early notions of personality were that you could tell someone's personality by touching their skull. So you've likely studied this before. This concept is phrenology, the idea that different parts of the brain or of the head are devoted to different types of functioning and thinking. So this in itself wasn't far off. We know that different structures in the brain do play a role for specific functions, but of course there's a lot of contribution from different areas of the brain as well. And we certainly know now that you can't determine whether or not someone has a personality based on feeling the bumps on their head. So the DSM-5 identifies 10 personality disorders and separates these into 3 groups or clusters. The first being odd or eccentric behavior. This includes paranoid, schizoid, and schizotypal personality disorders. The second is dramatic, emotional, or erratic behavior. This includes antisocial, borderline, histrionic, and narcissistic personality disorders. And then the third is anxious or fearful behavior. This includes avoidant, dependent, and obsessive compulsive personality disorders. This is from your text so that you can look at it later to get a closer view. This gives you an idea of the kind of categorization or clustering and the traits that are specific to each of these. So this DSM-5 listing is called a categorical approach. It assumes that problematic personality traits are either present or absent, that a personality disorder is either displayed or not, and that a person who suffers from a personality disorder is not markedly troubled by personality traits outside of that disorder. The assumptions are frequently contradicted in clinical practice, however. As a result, many theorists suggest that disorders differ more in degree than in type of dysfunction. So the dimensional approach, each trait is seen as varying along a continuum that's extending from non-problematic to extremely problematic. Given the inadequacies of a categorical approach and the enthusiasm for a dimensional one, the framers of the DSM-5 initially proposed significant changes, but this proposal was met with enormous concern and criticism in the clinical field, leading to a reversion back to the categorical approach. And so this, as is some previous disorders that we've discussed in the course, has been shelved for further study. So we'll see if there are changes in the next edition. All right, so we'll look now at the odd personality disorders. The cluster of odd personality disorders includes, again, paranoid personality disorder, schizoid personality disorder, schizotypal personality disorder. People with these disorders display behavior similar to, but not as extensive as schizophrenia. Some clinicians believe that these disorders are actually related to schizophrenia, and thus call them schizophrenia spectrum disorders. We'll look first at paranoid personality disorder. It's characterized by deep distrust and suspicion of others. The suspicion is usually not delusional. The criticism of weakness and fault in others is typically present, particularly at work. And this affects as many as 4.4% of US adults. It's more common in men than in women. From a psychodynamic perspective, theorists trace the pattern back to early interactions with demanding parents. From a cognitive perspective, theorists suggest that maladaptive assumptions such as people are evil and will attack you if given the chance are to blame. And from a biological perspective, theorists propose that genetic causes are at root, and they've looked at twin studies to support this model. As with all personality disorders, treatment for paranoid personality disorder is very difficult. Few come to treatment willingly, and others distrust and rebel against their therapist when they do. Therapy tends to have a limited effect and tends to move slowly. With the object relations approach, there's an emphasis on relationships specifically and the desire for satisfying relationships. From a behavioral therapy perspective, there's a focus on anxiety reduction and interpersonal problem-solving skills. From a cognitive approach, the therapy aims to develop more realistic interpretations of other people's words and actions and to increase awareness of others' perspectives. And then drug therapy appears to be limited in its effectiveness. There is little systemic research on these treatments so far. A look now at schizoid personality disorder. Schizoid personality disorder is characterized by persistent avoidance of social relationships and limited emotional expression. Patients tend to be withdrawn and reclusive. They tend to have a self-focus, flat, cold, and humorless affect. And this is present in 3.1% of the adult US population. It's slightly more likely to occur in men than in women as well. Psychodynamic theorists, particularly object relations theorists, link schizoid personality disorder to an unsatisfied need for human contact. And cognitive theorists propose that people with schizoid personality disorder suffer from deficiencies in their thinking. Social withdrawal and reluctance to enter into or participate in therapy again creates a lot of difficulty in treatment effectiveness. When treatment does occur, cognitive behavioral therapists focus on thinking about emotions, behavioral therapists focus on teaching social skills, and group therapy offers a safe environment for social contact. Again, drug therapy tends to be of little benefit. Schizotypal personality disorder involves a range of interpersonal problems, including extreme discomfort in close relationships, odd patterns of thinking and perceiving, and this can include ideas of reference, beliefs that unrelated events pertain to them in some important way, bodily illusions, sensing an external force or presence, and belief in extrasensory abilities and or magical control over others. They tend to also have trouble focusing and strange communication patterns. Behavioral eccentricities are also in place, including excessive or repetitive organizing, bizarre dress, and inappropriate, flat, or humorless emotion. So schizotypal symptoms are linked to some of the same biological factors that are found in schizophrenia, such as high dopamine activity. There also tends to be family conflicts and psychological disorders in parents, and high activity of the neurotransmitter dopamine in large brain ventricles, smaller temporal lobes, and loss of gray matter. Clients are helped to reconnect and recognize the limits of their thinking and powers in treatment. From a cognitive behavioral approach, the therapist tries to teach clients to objectively evaluate their thoughts and perceptions and provide speech lessons and social skills training. Drug therapy tends to involve antipsychotic drugs, and this appears to be somewhat effective in reducing certain thought problems. Again, therapy is difficult. We'll look now at the cluster of dramatic personality disorders, which includes antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. So these disorders have behaviors that are so dramatic, emotional, or erratic that it's almost impossible to have relationships that are truly giving and satisfying. The causes of the disorders are not well understood, and treatments range from ineffective to moderately effective. We'll look now at antisocial personality disorder. Antisocial personality disorders are characterized by persistent disregard and violation of others' rights, repeated lying, recklessness, and impulsiveness. The person can be cruel, sadistic, aggressive, and violent. And aside from substance use disorders, this is the disorder most linked to adult criminal behavior. The DSM-5 requires that a person be at least 18 years of age to receive this diagnosis, but antisocial personality disorder patterns are often displayed before the age of 15. Surveys indicate that 3.6% of US people meet the criteria for this disorder, and is 4 times more common in men than women. Higher rates of alcoholism and other substance use disorders tend to occur within this group, which connects with the recklessness and impulsivity. From a theoretical perspective, the psychodynamic theorists propose that the disorder begins with the absence of parental love, leading to a lack of basic trust. Many behaviors suggest antisocial symptoms may be learned through modeling or unintentional reinforcement. From the cognitive view, People hold attitudes that trivialize the importance of other people's needs, and from the biological perspective, hormonal and brain abnormalities. Again, treatments are typically ineffective. Some cognitive therapists guide clients to think about moral issues and others' needs, which is difficult when you are dealing with someone who has low or no empathy. Therapeutic community approach has been tried in hospitals and in prisons, and atypical antipsychotic drugs also have been tried, but systemic studies are still needed. Look now at borderline personality disorder. Borderline personality disorder is characterized by great instability, including major shifts in mood, an unstable self-image, impulsivity, and unstable interpersonal relationships. Suicidal actions and threats are increased for this population, so about 5.9% of the adult US population displays this disorder, and close to 75% of those diagnosed are women. The course of the disorder varies from person to person. From a psychodynamic perspective, theorists consider early parental relationships when explaining the disorder. Object relations theorists propose a lack of early acceptance or abuse and neglect by parents. And biological theorists suggest that there are biological abnormalities such as overly reactive amygdalas, underactive prefrontal cortex, lower brain serotonin activity, and other genetic links. The biosocial theory presents results from a combination of internal and external forces, and some sociocultural theorists suggest that cases of borderline personality disorder are particularly likely if the culture changes rapidly. So look now at treatments for borderline personality disorder. Psychotherapy is extremely difficult. Therapists must balance empathy and challenge, and this is difficult in particular because people with borderline personality disorder and personality disorders in general tend to need more empathy to be able to establish relationship in the therapeutic setting, but they also tend to have ideas that need to be challenged, and so finding that balance can be very difficult. Clients are likely to have poor boundaries and to be manipulative, and they can eventually, the therapy itself can eventually lead to some improvement, but again, it's very difficult, and the treatment doesn't tend to yield significant improvement. One that has been more effective is dialectical behavioral therapy, and this is an integrative treatment approach. It's well supported by research, and so for that reason, it is the current treatment of choice. It's similar to cognitive behavioral therapy in that it has homework, psychoeducation, social and other skills, modeling, goal setting, reinforcement of appropriate behaviors, and a collaboration between the therapist and the client of an assessment of the client's thinking. It emphasizes appropriate client-therapist relationships with a humanistic approach. Antidepressants, anti-bipolar, anti-anxiety, and antipsychotic drugs have been effective, but they're controversial because this population has a higher risk of suicide, and antidepressants, in particular anti-anxiety, antipsychotic drugs, also have side effects that can increase the likelihood for suicidal tendencies. So when drugs are used as a part of treatment, they are strongly recommended as an adjunct to psychotherapy, and specifically dialectical behavior therapy. A look now at histrionic personality disorder. This is characterized by extreme emotionality and attention seeking. People in this category tend to be always on stage or performing. They tend to have a high need for approval and praise from others. They tend to be vain, self-centered, and demanding. And this affects 2 to 3% of US adults, with males and females equally affected. From a psychodynamic perspective, theorists believe that children experience unhealthy relationships. From a cognitive perspective, theorists look at the lack of substance and the extreme suggestibility found in people with the disorder. And from a sociocultural and multicultural perspective, theorists believe that the disorder is caused in part by society's norms and expectations. From a treatment perspective, cognitive therapists try to help change their belief that they are helpless and to try to help clients understand how to develop better and more deliberate ways of thinking and solving problems. Psychodynamic therapy and group therapy has also been applied to help clients deal with their dependency. And drug therapy, again, is less successful here, except as a means of relieving the depression. A look now at narcissistic personality disorder. Narcissistic personality disorder is characterized by grandiose behavior, a need for much admiration, and feeling no empathy with others. As much as 6.2% of adults display narcissistic personality disorder, and up to 75% of these are men. Behavior is common among normal teenagers and does not usually lead to adult narcissism. From a psychodynamic perspective, theorists focus on cold, rejecting parents. From an object relations perspective, theorists interpret grandiose self-representation as a way for people to feel self-sufficient and without need of warm relationships. From a cognitive behavioral perspective, theorists propose that narcissistic personality disorder may develop when people are treated too positively rather than too negatively early in life. And many social cultural theorists see a link between narcissistic personality disorder and errors of narcissism in society. This is one of the most difficult personality patterns to treat. Clients who consult therapists usually do so because they're trying to seek relief from other symptoms for other psychological disorders. Once in treatment, the individuals may try to manipulate the therapist into supporting their sense of superiority, and none of the major treatment approaches have had much success here. We'll look now at anxious personality disorders. The cluster of anxious personality disorders includes avoidant personality disorder, dependent personality disorder, obsessive compulsive personality disorder. People typically display anxious and fearful behavior, and as with most of the personality disorders, the research is very limited. So look first at avoidant personality disorder. Avoidant personality disorder is characterized by discomfort and inhibitions in social situations, feelings of inadequacy, and extreme sensitivity to negative evaluation. Theorists often assume that avoidant personality disorder has the same causes as anxiety disorders, and the research is not directly tied the personality disorder to the anxiety disorders, however. From a psychodynamic perspective, theorists focus mainly on the general sense of shame that's felt. Early toileting experiences especially are emphasized. From a cognitive perspective, theorists believe that harsh criticism and rejection in early childhood may lead people to assume that their environment will always judge them negatively. And from a behavioral perspective, theorists suggest that people with this disorder typically fail to develop normal social skills. So treatment for this disorder, people seek acceptance and affection in therapy. The disorder is treated like social anxiety and other anxiety disorders. Group therapy can be helpful because it provides practice in social interactions, and anti-anxiety and antidepressant drugs are also sometimes useful. Treatments have had modest success, however. We'll look now at dependent personality disorder. Dependent personality disorder is characterized by pervasive, excessive need to be taken care of, being clingy and obedient, and a fear of separation from loved ones. There's a great risk for depression, anxiety, and eating disorders, and they may be especially prone to suicidal thoughts. Fewer than 1% of the population experiences this disorder, and men and women are affected equally. From a psychodynamic perspective, Freudian theorists believe that there are unresolved conflicts during the oral stage. Object relations theorists believe that early parental loss or rejection may be at play. And then other theorists suggest that over-involved and overprotective parents are the cause. Behaviors propose that there are unintentional rewards and punishments for the person's behavior. And then cognitive theorists have identified two maladaptive attitudes. One, that the person feels inadequate and helpless to deal with the world, and two, that they cope with this feeling of inadequacy and helplessness by finding a person to provide protection. Treatment for dependent personality disorder can be at least modestly helpful. Psychodynamic therapists focus on many issues similar to those of depression, and cognitive behavioral therapists help the clients to challenge and change their assumptions. Antidepressant drug therapy can be helpful when depression is manifested, and then group therapy can provide the clients with opportunities for peer support. Look now at obsessive compulsive personality disorder. This disorder is characterized by preoccupation with order, perfection, and control. Individuals with this disorder tend to lose all flexibility, openness, and efficiency. As many as 7.9% of the adult population are diagnosed, with white, educated, married, and employed individuals receiving the diagnosis most often. Men are twice as likely as women to display. From a theoretical perspective, psychodynamic explanations dominate for obsessive compulsive personality disorder, and because of the nature of this theory, there is limited research. From a Freudian perspective, it's believed that the individual has regressed to the anal stage of development. Cognitive theorists offer limited theories about the origins of the disorder, but they propose that illogical thinking processes help to maintain it. And people do not usually believe there is anything wrong with them when they experience this disorder, so they're unlikely to seek treatment. But when they do, they respond well to psychodynamic or cognitive therapy and also to SSRIs. So a quick moment to distinguish between obsessive compulsive personality disorder versus obsessive compulsive disorder. There are some similarities. Clinicians believe that the two disorders may actually be closely related, and often the criteria for both is met when one is present. But the research hasn't actually found a consistent link between the two. And people who are experiencing obsessive compulsive personality disorder are more likely to suffer from major depressive disorder or generalized anxiety disorder than those who have obsessive compulsive disorder only. A look now at how multicultural researchers may have neglected personality disorders. Despite limited multicultural research on personality disorders, clinical theorists suspect that differences do exist, especially with regard to borderline personality disorders. About 75% of all people who receive a diagnosis of borderline personality disorder are female. And some culturally based characteristics may be acceptable traits and behaviors. More multicultural research then is needed into personality disorders. And finally, are there better ways to classify personality disorders? Some criteria used to diagnose the DSM-5 personality disorders cannot be observed directly, and clinicians differ widely in judgments about when normal personality style becomes a disorder. Personality disorders often are very similar to one another, and people with different personalities may qualify for the same DSM-5 personality disorder diagnosis. So another way that we might approach personality is through the Big Five personality trait theory, and you should be familiar with this from intro. There's a large body of research that's been conducted with diverse populations that consistently suggests that the basic structure of personality may consist of these 5 super traits or factors. Those are neuroticism, extroversion, openness to experience, agreeableness, and conscientiousness. And each of these factors collectively is referred to again as the Big Five, and they consist of a number of subfactors. Theoretically, everyone's personality can be summarized by a combination of these super traits. Another way that we could look at these is to look at a newer distinction, which is personality disorder trait specified, or PDTS. In this perspective, individuals whose traits significantly impair their functioning would receive the diagnosis, and clinicians would further identify and list problematic traits and the rate of severity of impairment caused. There are 5 groups of problematic traits that would be eligible for a diagnosis, and those include negative affectivity, detachment, antagonism, disinhibition, and psychoticism. For negative affectivity, people experience negative emotions frequently and intensely, and they exhibit one or more of the following: emotional lability or unstable emotions, anxiousness, separation insecurity, perseveration, which in this case refers to repetition of behaviors even though there is consistent failure, submissiveness, hostility, depressivity, suspiciousness, and strong emotional reactions, or reactions that are overreactions to emotionally arousing situations. For detachment, there's a tendency to withdraw from other people and social interactions, and the person may also exhibit one or more of the following: restricted emotional reactivity, meaning little reaction to emotionally arousing situations, depressivity, suspiciousness, withdrawal, anhedonia, and intimacy avoidance. For antagonism, people may behave in ways that put them at odds with other people, and they may also exhibit one or more of the following: manipulativeness, deceitfulness, grandiosity, attention-seeking, callousness, and hostility. With disinhibition, people behave impulsively without reflecting on future consequences, and they may also exhibit one or more of the following: irresponsibility, impulsivity, distractibility, risk-taking, and imperfection disorganization. And finally, for psychoticism, people engage in unusual and bizarre experiences, and they may exhibit one or more of the following: having unusual beliefs and experiences, being eccentric, and having cognitive and perceptual dysregulation, or odd thought processes and sensory experiences. Diagnostic criteria for this disorder would be that the person is impaired significantly by any of the 5 trait groups, or even just be significantly impaired by 1 out of the 25 traits that make up those groups. And this approach to personality disorders may prove superior to the current DSM-5 categorical approach, but it's still controversial in the clinical community. All right, that is personality disorders. If you find it helpful to complete the learning curves, please do so. They're not required. And there's also a clinical choices activity in the Launchpad course room that, again, if you find useful, you can do, but is not required. If you have questions, let me know.